Record. Instrumental in shaping clinical practice guidelines for chronic kidney disease, developing policy initiatives to address health disparities, and increasing diversity in the biomedical sciences. He is Distinguished Professor and Executive Vice Chair for Inclusive Excellence for the UCLA Department of Medicine and co-director of the UCLA Clinical and Translational Science Institute Community Engagement Research Program. For 30 years, he has worked to promote community-partnered research. Notably, he and his lead community partner developed a community faculty track at Charles Drew University in 2009 to better inculcate community voice and social determinants of health into health research and education. He was a site principal investigator for the multi-site NIH-NIDDK funded African American study of kidney disease and hypertension and the AASK cohort study, the largest comparative drug intervention trial focusing on renal outcomes conducted in African Americans. At present, he serves as PI or multi-PI for 6 NIH research and training grants. An elected member to the National Academy of Medicine and new member of the NIH Council of Councils, he has co-authored over 500 articles in peer-reviewed journals and over 40 book chapters. Dr. Norris?
Thank you very much for a kind introduction, and good afternoon to everybody there in New York at Cornell. And it's my pleasure today to talk a little bit about what I think are sort of some of the best practices for integrating race, ethnicity, and ancestry in medical care and research, as well as some other social variables. And so I want to thank the Cornell Health Equity Seminar Series leadership for the invitation, and my many colleagues, mentors, family, and friends for supporting me along my journey. My disclosure, my conflicts of interest are here. My main conflicts of interest: I believe in a society grounded in equity and justice, and I am not an expert in anything, but I will do my best to share what I think are some things that might be of value. So I'll start with a case vignette. This is a 64-year-old female, 77 kilograms, with a history of diet control, type 2 diabetes. At a health fair, was found to have elevated blood pressure. She is a non-Hispanic African American with no family history of kidney disease and was recently laid off from her CDC job. Her labs and vital signs are shown here. Blood pressure slightly elevated, hemoglobin A1C is a little elevated. Her eGFR with a race modifier is just at the border of stage 2 and stage 3 at 62 milliliters per minute. And she was told that because she was African American and only stage 2 CKD, she would be started on hydrochlorothiazide 25 milligrams a day. And some of the questions are, should her race and ethnicity determine her medication and GFR? Is race directly related to any biological factors that might influence her clinical outcome? When and how should we use race and ethnicity in medicine? Should we use ancestry informative markers instead of race to add more precision to her care? And should patient-centered care consider race, ethnicity, and other socio-demographic identifiers? So just as a sneak preview, the direct therapeutic plan should be informed by clinical lab data, imaging, and or pathology findings. We should not use race, ethnicity, or other social group modifier information in the direct therapeutic plan. For patient-centered care, there we want to add our social and family history, and that includes race, ethnicity, associated population data that gives us some estimates, socioeconomic factors, religion, health beliefs, behaviors, etc. And that allows us to activate and refine sociocultural and structurally sensitive ancillary interventions, tailored lifestyle recommendations, health-related social needs, multidisciplinary care team, etc. So here we really want, for patient-centered care, to use an individual assessment, not group-level stereotypes. And ideally, we do it in partnership with our patients using shared decision-making. So why do we need a talk like this? So we'll talk a little bit about the historical context and evolution of race in medicine. and then some of the clinical applications and misapplications, and then what I think is a relatively simple way forward. So I'll start with this aphorism for a quote from Paulo Freire from Pedagogy of the Oppressed. It would be extremely naive to expect the dominant classes to develop a form of education that would enable the subordinate classes to understand social injustices critically. And so that's why it's important that we go over these elements in medicine for research and for care, because we need to make sure that education actually does occur. So when we think about race, typically race in the United States is linked with Carl Linnaeus, the father of modern taxonomy. And he outlined socially constructed hierarchical groupings, um, and also added specific personal attributes, which he considered innate, that established not only race, but racism. And I've listed here his groupings and some of the innate attributes he associated with them. And as you can see, they are not, they differ by groups, and particularly with American Indians being regulated by customs, Asians ruled by opinions, uh, persons of African descent ruled by caprice, and persons of European descent governed by laws. And while you may think that that's old, that was from 1735, that was taught in college that was taught when I was in college. So the term race is commonly used as a misnomer. It's a guess of continental ancestry. In reality, there's one race, the human race. So for what we call race and ethnicity, we really should use, I think, a better term is racial and ethnic identities, because identities makes it clear it's just an identity and not some scientific construct. And then Hispanic and non-Hispanic, for some reason in the United States, we've split the world into two ethnic groups by language. And how that came about, I'm not really sure. And what its value is pretty nebulous still. So race essentially is a modern idea, and importantly, it's not based on biological scientific fact. Again, these racial and ethnic identities are socially assigned group labels, and they're constructed and circulated within our society based on socio-political contexts. I think of it kind of simply, racial and ethnic identities, that's how society sees an, a person or a group and how we see each other. And racism and other identity-based isms are what society does to you based on how it sees you, be it classism, sexism, religious groups, et cetera, et cetera. So one thing I think is helpful is to think of race through a conceptual model. And this was developed by Tom Leviste, who is Dean, School of Public Health in Tulane. It was at Hopkins at the time. And Tom structured it like this, where we have race as a latent, unobserved factor, and then we have this physical manifestation, someone's appearance, usually skin color, but some other facial characteristics or other physical characteristics that may be associated with people based on their culture, based on their tribe, their nationality. It gets linked to a culture. In society, those groupings and how people may appear as a group get separated into these different groupings, which lead to different external risk exposures. And that can also influence health and wellness and behavior. One's nationality or tribe can influence one's health and wellness and behavior. And then how a group responds to how they are structured in society can influence their health and wellness and behavior. And this leads to differences by race and health outcomes. So if we think of race and ethnicity and the path to health, we have all of these factors occurring, and race and ethnicity become proxies for all these factors that are in there. And so ideally, what we want to do is measure those factors to be more precise for a given health condition as to how race and ethnicity may be associated with health outcomes. So let's take a little look at some of the clinical applications and potential misapplications of racial and ethnic identity in medical care and research. So it's important that we think about why we're often labeling people by these different groups. Um, and we do this particularly from a public health perspective to get population level data on incidence, prevalence, trend data. And that's important because it allows for group level education, outreach, screening, um, introducing policies and interventions based on um, the findings we see, and then monitoring to see if things are getting better or not. And so we have a variety of different labels upon which we develop these groups, and then we look at group differences. And importantly, when group positionality leads to social advantage or disadvantage, and that social advantage or disadvantage leads to health advantage or disadvantage, then we see health disparities. So importantly, as a variable, racial and ethnic differences mainly reflect group level social position. And I think that's important for us to really get out to our colleagues. So if we look at population level data, this is end-stage kidney disease. On the left, uh, the vertical axis is the relative prevalence of end-stage kidney disease, and the horizontal axis are groups, racial ethnic groups. And you can see there's a nearly 8 to 9-fold difference in the prevalence by different racial ethnic groups. And importantly, when we think about different groups, which are such broad categorizations, here we see some disaggregation with Native Hawaiian Pacific Islanders at the far end, with the highest prevalence of all groups measured here. But frequently, they're labeled under Asian, and if they were labeled under Asian, because their numbers are small, Asian would just go up a little bit, and we wouldn't realize that that group has this high prevalence and really needs education, outreach, and intervention. Similarly, we can see differences in groups by income, education, and other factors. So one thing that's important is, well, would you consider prescribing a blood pressure medication or modifying an eGFR value for a patient because of their religion? And I don't want necessarily people have to, since we're on Zoom and not in an audience, most people probably would not prescribe a medication or modify a GFR because of someone's religion. Probably would not do it because of marriage status. Probably not because of level of education. Probably would not because of income, independent of affordability. But we've been doing a lot for race ethnicity, but as a variable, it's essentially the same variable. And so we should not be raising our hand for race or ethnicity, right? So if we stop for a minute and move beyond race and ethnicity stereotypes, let's take a look at them as variables. When we think of groups and group level differences, to assign a group level difference equally to each group member, and that could be for initiating care, for a modifier and a formula, that variable should have 3 characteristics. It should be consistently measured, it should be ordered, and directly related to a physiological or clinical outcome. Hemoglobin A1C is consistently measured, it's ordered, and it's directly related to diabetes and diabetes-related outcomes, some cardiometabolic, some cardiovascular maybe. Blood pressure is consistently measured, it's ordered variable, it's directly related to cardiovascular outcomes, okay? Racial and ethnic identities are nominal variables. They're not consistently measured, they're unordered, and they're not directly related to any physiological or clinical outcome. Okay. So because of that, we should not use race or ethnicity as a basis for assigning treatment with a specific medication or an individual level formula modifier. And we don't, and the reason to not use it is not because of racial or social justice, but because of methodological rigor. That's called an ecological fallacy, where we take social variables and take group level associations and any differences there and assign them equally to each individual member. So as a nephrologist, if we took rather than race or ethnicity, if we took another social variable like religion or marriage or favorite color, and patient came in and we saw some group level differences and put in a formula, and someone came in and we had a modifier for EGFR, and someone said um, to me, well, we want to get your mother's EGFR here. I just need to know what religion she is so I can give her a modifier. Or I want to know um, what her favorite color is so I can give her a modifier. I would think that person's crazy. But we've used race and ethnicity for many years, not recognizing methodologically it's in the same category as other social variables, because that's what it is. Here's an example. So single drug therapy for hypertension, there's a lot of single drug therapy studies that have found difference in blood pressure response to different therapeutics based on race or ethnicity. So this was an early study in the VA cooperative study that found Black patients were more likely to respond to diuretics than white patients. And P level is very significant. And the question is, what should the recommendations be for using diuretics for Black patients versus white patients? And actually, in the Joint National Committee report many years ago, there was a recommendation to use specific drug therapies for racial ethnic groups. Let's look at the data. So this is the number of this is in the study. This is the number of patients achieving target blood pressure response to different antihypertensives, and 93% of Black and white patients responded the same. 7% responded differently, right? And so there's the data, 7% responded differently. And what we should be saying is, why did 7% respond differently? And that should be a research question. And then we look into what may be causing those differences: social determinants of health, weathering, adherence, diet, stress. But to take 7% and say, because 7% respond differently, we're going to assign the entire group to have a different response is the fallacy. Okay. And that's where the problem lies. So again, we don't assign social group differences equally to each group member. And it's not because of racial or social justice, it's because of scientific justice. Now, a lot of times, some of the confusion becomes, we frequently talk about socio-demographic variables. And so there's social variables and demographic variables, and sometimes they're lumped together. And demographic variables could be, potentially used as biologic per se. And so age, sex, some others maybe, depending on the outcome, could be biologic. If it's an age-related health condition, if the differences in sex are related to sex hormones and sex organs, or it could be sociologic. It could be related to ageism or sexism. And so it really depends on the outcome of interest. And we'll take a look at that again in more detail in just a minute. So some of the complexities are due to race and ethnicity being linked to how groups are treated in society. And so it becomes conflated or integrated with many other issues in society, such as social determinants of health and levels of stress and distress. But importantly, although there may be group differences, each individual is exposed differently to disadvantages in education, employment, income, housing, et cetera, et cetera. And because each individual is exposed so differently, we can't assign group differences equally to each individual. Now, in research, when we're doing research, we don't want to just blindly, a lot of times we do research and we use adjustments for race and ethnicity, and we don't want to do that blindly. We want to think about, is there a theoretical or construct or empirical link of race and ethnicity and a given health question for a research study? And importantly, we want to try to measure the underlying factors if possible. So we want to, and also we want to carefully use race and ethnicity as covariates in statistical analyses because they're proxies for so many known and unknown factors. And we also want to watch for overadjustment because education and income as variables in different studies, they may be influenced by the role of race and ethnicity in society. So frequently we'll do stratified analyses to visualize group differences and then to see or assess the range of possible subgroup baseline differences. And then we can use that information to try to generate new hypotheses. So I'm going to show a couple of examples next. So this is a paper from Dr. Popescu and Escarze and colleagues here at UCLA, and it's on racial residential segregation, socioeconomic disparities, and white-black survival gap. And in their paper, they put this theoretical model for why they believe they might see health outcome differences. And so we have institutional personal racism, the experience of discrimination, other forms of discrimination, that institutional racism leading to racial residential segregation, and that leads to racial differences in socioeconomic status and racial differences in neighborhood environment, and those all lead to potential differences in health outcomes. So it's very important and very helpful, at least, to have these constructs when one is looking at these differences to help think about how and why we might see differences, and then looking specifically at some of the underlying factors, if possible, depending on the data set that we're using, or if we're constructing a study, data that we want to collect. This is a study, statin use among men and women following coronary artery bypass surgery. And I used men and women rather than race and ethnicity because I wanted to highlight this study because this is men and women as a social group. When we think about medication use between men and women, there's nothing biologically different in why men or women per se should receive medication differently for a condition that's not driven by sex organs or sex hormones. And so this is from Dr. Stafford and colleagues. And here what we do see is stratifying the groups by men and women. There, I've highlighted the areas where there are difference in some of the demographics and some of the statistical differences. And we can see that those could be driving some differences we may see in statin use, the prevalence of kidney disease, congestive heart failure, ejection fraction, smoking, et cetera, et cetera. And fortunately, they found that there was no difference. But it's good to think about how we're conceptualizing these problems. And a lot of times, if we're looking at social groups, then stratifying the baseline characteristics by the social groups to get an idea of the distribution of factors that may differ between the groups. So importantly, race and ethnicity and other social identities are not risk factors for poor health. And I think a lot of times we see papers and reports and casual language where they're listed as risk factors, but they are not risk factors for poor health. They are risk factors for structural discrimination, and structural discrimination is a risk factor for poor health. Okay, so when we see these differences, racial ethnic differences, or class differences, sex differences, religious differences in health, then we want to measure factors that could be underlying them. For race ethnicity, we think about many of the social determinants of health, discrimination, internalized racism, and other factors. So it's important to sit back and sort of reflect on race ethnicity and sort of say that mostly it tells us about group estimates, but it doesn't really tell us about individuals. And that's important. When we think about clinical trials and or other forms of clinical research, the use of race and ethnicity, when possible, we want to disaggregate race and ethnicity to have a better idea of what's going on with different racial ethnic subgroups, be it by nationality or other. And again, we want to define the concepts, be clear about the measurements, disclose limitations, and we would have all those factors go into our grant proposal or into a publication when we're analyzing it. The study methodology, similarly. And again, sometimes we have limitations based on legacy data sets that we have information that's collected the way it's collected. We also have other opportunities with new studies to think about maybe collecting data a little differently. When we think about clinical trials, there we think about community engagement and partnership, building trust, and ways to sustain partnerships in order to have adequate representation from all groups. And it's also important to account for time for outreach because there may be more time needed to outreach for groups that are underrepresented and underrepresented for a variety of reasons. And we're going to talk about those reasons in just a minute. So one term that's been used, particularly when thinking about research outreach to subordinate groups and in building and gaining trust, is that those projects or activities should proceed at the speed of trust. Okay, so we want to proceed at the speed of trust. So a lot of times we want to force things to happen at a particular rate, and that may not be helpful in trying to improve representation of underrepresented groups, particularly subordinate groups, because of their treatment in society. So when we think about why do we need broad representation in clinical trials, if we think about dominant and subordinate culture and these many different groups that are treated differently based on being a member of the dominant or subordinate group, typically the subordinate group is marginalized. They suffer from inadequacies based on the inequitable distribution of health and life-affirming resources and opportunities. And although we all have stress and then distress, there's much more excess stress and distress when you're a member of the subordinate group. So that typically leads to social exclusion, low socioeconomic status, limited access to healthy living, healthy and quality of health care. And that leads to multimorbidity, trial exclusion, distrust, non-participation, high social needs, often non-participation, particularly if we've not allowed resources to address those. It also leads to maladaptive neurocognitive processing. And in the brain's trying to deal with all this excess stress, and conceptually, it's believed that there's realignment of what's called global workspaces in our brain. And it adversely impacts two areas, our memory and our ability to implement tasks. Memory and our ability to implement tasks. So if we're enrolling people in clinical trials, the two things we want them to do is remember what we told them and to implement it. And so that could lead to poor adherence. So the fact that they may be suffering from this excess stress in and of itself could lead to poor adherence. Also, there may be maladaptive coping to this stress, and that can lead to maladaptive or destructive health behaviors. And these also happen when we take care of our patients. Or if our patients have this excess stress, we want them to remember what we told them and then to do it. And they may be challenged to do that if they're under this excess stress. There's also maladaptive biological processing with activation of the sympathetic nervous system, neurohormonal systems, gene expression, activation, and activated gene expression for a variety of factors, cardiometabolic, GI systems, microbiome, epigenetic changes. And all these also lead to group level differences in morbidity, drug response, side effects. And so together, these factors and then a few others is what lead to differences, potential differences in group level outcomes in clinical trials can limit generalizability if we don't have broad representation. And notice I did not talk anything about some genetic differences between groups. Well, what about race and genetic ancestry? One thing that happened with a lot of conversations around racial and ethnic modifiers was people said, well, instead of using race ethnicity, let's use genetic ancestry informative markers instead. And this is an opinion piece from PNAS. And what they said is, whereas genetic ancestry is a measurable biological parameter, race is a social construct that has often been labeled biological. So that was their way to kind of differentiate the two. But the question is, when we think about race, when we think about genetic ancestry as a biological parameter, has anybody here ever taken care of a patient and said, you know, Mrs. Jones, this is a really tough case you have here. I need to order a 23andMe to figure out what's going on. And I'm going to go out on a limb and say nobody here has ever done that. And there's a reason why you've never done it. Is because genetic ancestry has no biologic information in it. It's a genetic measurement, but it has no biologic information. It's a nominal variable. There's no direct relationship to health. It gives us information about ancestry. Ancestry tells us about history, geography, sociology, anthropology, etc. So basically, it's a genetically measured social construct, but it has zero biological information in it. Right? It's these single nucleotide polymorphisms that measure frequencies between populations to estimate percent ancestry. Right? And we use it for population level research linking health conditions with large geographic areas, but it has no value in taking care of patients. What is of value is health relevant gene variants, gene polymorphisms to inform care. BRCA2 gene mutation could be helpful. We look at different genetic biomarkers for cancer chemotherapy or as part of a health assessment. So those have biologic information. The ancestry measurements have no biologic information. Okay. So racial and ethnic identity do not equal ancestry informative markers, just like racial and ethnic identity do not equal socioeconomic status. There may be some associations between the two, but they are different constructs and we use them to answer different questions. So given that, what is sort of the way forward? I think bedside care that is distinguished, exceptional, and individualized is one way to go and allows us to continue to use DEI. I think it's important to use DEI where we can. And we want to do this in the setting of shared decision making. So first, importantly, race and ethnicity or racial and ethnic identity, major group level constructs that are associated with health, but they're not causal, and they reflect multiple domains of health that impact individuals differently. They mainly reflect group level social position, not individual group members. And then a lot of times people talk about group culture, and a lot of that indigenous group culture that gets described in the media is not really a group culture, but it's an adaptive or maladaptive subgroup culture from dominant subordinate status. And so we really want to be cognizant of that as well. So when we think about evidence-based medicine, we want to use clinical data, lab data, imaging, pathology findings, et cetera. That should inform evidence-based guidelines and patients, the diagnostic plan, treatment plan. We don't use race, ethnicity, or other social group information in that part of our plan. We don't use race, ethnicity, or social group information as individual level clinical algorithm modifiers. We um, um, BRCA2 mutations, hemoglobin S, cystic fibrosis markers, all of those are absolutely fine and important. And importantly, we do not make or exclude a diagnosis based on race, ethnicity, religion, or other social variables. Now, we think about patient-centered care. What we're going to add to the evidence-based care to refine it is our social history that includes race, ethnicity, socioeconomic status, religion, health beliefs, behaviors, and our family history. And we use that to activate what we call social, cultural, and structurally sensitive ancillary interventions, right? That information may influence the order in which we have a differential diagnosis and the order for our testing, frequency of follow-up. If someone says to me, if I go get my blood pressure checked and my blood pressure is normal, and someone says, well, Keith, so you're a member of the African American community, and in general, they have higher blood pressures. That's fine. I don't want anybody adding any numbers to my blood pressure, right? My blood pressure is what it is. But what you can say is, because you're a member of a group that has a higher prevalence, even though yours is normal, I might want to monitor yours a little more frequently or something of that nature. So we get tailored lifestyle recommendations. We tailor we get more information about health-related social needs, and then decide on a multidisciplinary care team maybe. And so we're doing this individual assessment, and that ideally we do it as part of shared decision making. So we come back to our case in the beginning, and we ask, should her race or ethnicity determine her medication and GFR? And the answer is no. Is race directly related to any biological factors that might directly influence her clinical outcome? And the answer is no. When and how should we use race and ethnicity in medicine? For direct care, it should be ancillary, really based on the social and family history. And should we use ancestry informative markers instead of race to add more precision to her care? And let's not. Should patient-centered care consider race, ethnicity, and other socio-demographic identifiers? Yes, it should consider it. It goes into, but we want their individual, how their individual social and family history unfolds, and we use that to help refine and target patient-centered care for a given patient. So some final thoughts. Social group variables follow methodologic rules. So we do not assign social group differences equally to each group member. No social variable-based treatment and no social variable individual level modifiers. Not only race, ethnicity, we don't use religion, we don't use marriage status, and a variety of other factors. We want to take an anti-discriminatory mindset. When caring for a patient from a subordinate group, think first not what is wrong with them, but what has happened to them. So a lot of times people are thinking what's wrong with this person in the group, but it's really what has happened to them. And then we want to explicitly treat patients from subordinate groups as a person, because frequently they have not been recognized as individuals in society. They have been given subhuman status in many settings that they've traversed. So they're distrustful, and we want to start by recognizing their humanity. We don't want to be patronizing. We want to see them as a person, not a group stereotype. We want to engage with them. We might put our hands on their shoulder or on their arm. We'll shake their hand, look them in their eyes, show them respect as a person. And then we're going to target individual health-related social and cultural factors, health beliefs, and behaviors. So I'm going to wind up by saying education does not change the world. Education changes people, and people change the world. So I want to thank you again, the leadership for the Cornell Health Equity Seminar Series, for allowing me to speak with everybody today. And again, my colleagues, mentors, family, and friends for supporting me along my journey. And I'm happy to entertain any questions. And if possible, I'll even answer some.
Martin, you have
Martin?
a
And
question?
Martin?
Sure. Well, Keith, the brilliant survey of uh, such an important topic. What what do we do as medical educators in terms of arousing the future populations of practitioners to the way in which they might think about this? I mean, my sense is that uh, it's not a very prominent feature of medical education. And now some people are maybe even a little bit afraid to talk about it. But how do we get people to be sensitive to the need to continually try to move towards non-discrimination in care?
Yeah, I think this should be integrated into medical education, starting from medical school and into the residency and fellowship as well. And so that's what my office is doing here at UCLA. So I try to do this for the medical students. I have to kind of split it up because they have different levels of, of understanding of healthcare and research and the medical system. Some come in with a much more in-depth understanding of race, ethnicity, and racism, others not so much. So we try to think about how we structure education in the medical school so that it evolves over the 4 year or 5 year journey, whatever it might be. But for residents and for fellows, I think there we just do similar to what I just went through now. I think it's important to get it out there so people are are thinking about things in a way that maybe they haven't thought about them before.
Is there buy-in in many medical schools to the need to do this?
No, I haven't gone to Mint, so I've gotten buy-in from ours, so so that's good. Getting it put in here, but I haven't thought about a more broad level approach for dissemination. Maybe I'll talk to AAMC in academic medicine and see what they say about it. And maybe they do have I forget there's an ancillary journal they have on where they have lectures and curricula and things of that nature that can one can submit and put in there, and that might be something good to do. Don't be shy, everybody. Go ahead, Holly.
Hi, Dr. Norris. It's great seeing you again and hearing you. Always good to hear you talk. You talked a lot about how to handle race and ethnicity in clinical care, but I was wondering in terms of research, that's primarily my focus, and especially when looking at upstream factors associated with structural racism, for example, or measures of structural racism. How do you think we should handle race in that way?
Yeah, great question. So you know, it's so strongly linked to so many of those factors. And so I think when we see racial ethnic differences for a given condition, we think through what are some of those conceptually, what are some of those underlying factors? And then ideally, can we measure them? Are there opportunities to measure them? And there's advantages and disadvantages, right? So um, right now, under the present administration for NIH, for doing work in health disparities, health equity, um, even minority health, they want to focus on solutions and they want people to target measurable components. So you might look at residential segregation. You might look specifically at educational disparities, food insecurity, things of that nature. And so that's going to be important for the grants. So on the grants, they don't want to hear structural racism because they say, well, it's vague. We don't know what it means, et cetera, et cetera. So from a research perspective, it could make sense to sort of say we want to target specific things. The reality is those elements are part of a larger umbrella of factors that that are disturbed when you have large structural discrimination. So when you have structural racism, the discrimination is not limited to just a small set of factors. But I think where we are from a research right now, it's going to be important, particularly when you're putting in proposals, to identify some key factors that you think are going to be important to target, that you either have data on an existing data set or you're going to collect information on that. If you're going to does data exist or do you want to collect everyday discrimination? Do you want to look at internalized racism? Do you want to look at sort of the more social determinants? And so that's going to be important when we're thinking about research strategies. But the important thing is that we're going to be looking at those, and race and ethnicity are proxies that have identified that those are potential differences that we need to look into. I hope that answers it. Okay, David?
Dr. Norris, thank you. I very much appreciate this talk. By way of introduction, I'm David Scales. I'm an internal medicine hospitalist,
Cool.
and also a sociologist.
Very cool.
This has been a kind of a longstanding interest of mine, and I very much appreciate this talk because I wanted to kind of put something to you that's been a large conundrum of mine.
Okay.
Because just as an example, I do a lot of work at Lower Manhattan Hospital, which serves Chinatown, has a
Okay.
very large kind of Chinese population. And one of the things that was very interesting that came up during the pandemic was the fact that there were some studies that had come out of China, kind of in the very early stages of the pandemic, showing that there was a survival benefit for Chinese patients in Chinese wards and Chinese hospitals who received anticoagulation. And this was interesting because it is not standard practice for people to receive DVT prophylaxis if you're admitted to a Chinese hospital. So this was something that kind of created a lot of interest in. Obviously, with COVID, we know a lot more about kind of the coagulation aspects of it. But one of the things that's come up is there's some indication, and I'm very appreciative of kind of everything that you said in this talk. So I'm going to qualify this in just a second, of some degree of racial differences when it comes to coagulation. And what I mean by that is there's just on kind of the studies that we have, which do use race as this nominal classifier, right? We
Right.
find a differentiation between kind of people of East Asian origin, African origin, European origin, and differences in terms of kind of both of their pharmacokinetics when it comes to things like heparin or when it comes to things like DOACs,
Right.
as well as just baseline, probably genetic differences in the coagulation cascade. So we're seeing, so that question about 23andMe, like I almost wish I could order 23andMe because I would want to see kind of both kind of the some degree of the, the cytochromes that people might be having that might kind of lead to some differential kind of metabolization of some of these illnesses, some of these drugs, as well as the coagulation cascade.
Right.
Both of these are extremely complex phenomena that science hasn't yet elucidated what are probably likely genetic kind of differences between these. So the question that I have for you, and I
Mhm.
apologize for this large preamble,
That's, no, that's fine.
is essentially like we're faced with kind of the data that we have is currently based on race. And frankly, it sucks. We
Right.
know this is probably genetic, right? But we don't have enough data for me to differentiate. So we're in this situation where, like, when I'm working in Lower Manhattan Hospital and working with a predominantly Chinese population that probably is a little bit less prone to clotting and more prone to bleeding with some of the anticoagulations that we use, especially kind of at the standard doses, I'm a little worried I might be doing harm. And so in this situation of uncertainty, I'm faced with this problem of what do I do without racially profiling my patients, but also kind of where is the greater harm is essentially kind of what I'm struggling with.
Right. Great question. Great question. So 23andMe unfortunately says, I have 20% Asian ancestry, 20% European. And so it doesn't
I
give
meant
us
that
that.
glibly. I'm sorry. Yes, no, I understand.
Right. No, no, no. So what we want is, as you said, the genetic profile or the biologic profile for some of those different systems. What we do see, so say some reports came out of China and say there is, we get this data that says within the Asian community population, there is a 7% greater um there's 10% higher prevalence of abnormality in whatever clotting cascade or whatever that might be. The challenge becomes when that study was done, what was Asian? Was Asian northern China, southern China? Did it include India, Indonesia? Did it include Thailand? Right? So that becomes the problem, right? Um, so, but that being said, so from a scientific perspective, we say we're limited there. That being said, now you're in a setting where you have limited information and you're trying to make a guess. And so sometimes we use population level data and differences there, and we're making a guess to assign it to an individual, and we understand that it's not scientifically accurate per se, but given the scenario, we're going to do that guess because it's the only information we have. So that's, we do a lot of medicine based on limited information. So it's not that there's something wrong with it. We just need to understand that when we do it, the foundation upon which we're doing it.
Mm,
Right?
yeah,
Right?
no,
Because
that's helpful. Thank you.
right, because right now we look back 70, we say, well, 100 years ago, how are people practicing? They didn't know what they were doing in medicine, right? 100 years from now, they're gonna look back and say, oh my God, you see that talk they were doing at Cornell? Like, what the hell was Norris talking about? You don't know it, right? So our goal is so we know it's gonna change, but we're trying to do the best we can with the data we have now. And our goal is to try to, rather than wait 100 years for them to say we don't know what we're doing now, to see if we can get there in 15 years. And so, can we get to the point that we can have the ability to order tests to look at clotting cascade or whatever factors we think are more important to see, such that we have a, a biologic foundation rather than a sociologic association, which would be more direct. But in the absence of that, a sociologic association, if that's what we have, that's what we have. Let me go with it. Sound reasonable? Cool.
So we are at time. Dr. Norris, thank you so much for visiting with us and for presenting your research and recommendations. We really appreciate it. Everybody, I hope you have a nice weekend and a nice New Year's. Our next health equity seminar series will be the second week of January because nobody wants to do this the day after New Year's. We will have a panel. Dr. Safford and a couple other people are going to be talking about their Promotoris de Salud program. So we hope to see you there. Have a great New Year's, everybody. Great holiday.
All right. Take care, everybody. Happy holidays.
Bye, everybody.
Chat.